This is presentation number 17 in GIT series. Will be for cystic liver lesions, prepared by Prof. Sharaf and revised by Prof. Hani Sami. This is the typical appearance of what we call biliary hamartomas. Biliary hamartomas. A sort of caroli. Caroli usually is more dilated, more dilatations are seen, and caroli in RCP is cystic dilatations along ducts. So this will be another case of caroli where there are cystic dilatations along the biliary system with dilated biliary ducts amongst displacing and compressing the vessels, portal veins. Biliary hamartomas tend to be small, scattered throughout the liver. In caroli disease, the bile ducts show cystic dilatation and the cystic areas communicate with the biliary tree. This is the difference, which could not be noticed during CT. Both are showing multiple small cysts, tend to be less than 10 in caroli, while in biliary hamartomas it's scattered throughout the liver. So in biliary hamartomas there are cystic changes, in caroli disease there are cystic changes, but this is connected also with dilated biliary radicals. Multiple hepatic cysts could be caroli. This is the appearance of the polycystic liver disease, and this can occur alone or with association of pancreatic cirrhosis, multiple cysts, and renal multiple cysts. So it can be polycystic disease of the liver alone, or it could be polycystic disease of the liver, kidney, and pancreas. Polycystic liver disease, on CTs there are diffuse multiple homogeneous and hypodense cystic lesions without enhancement. If complicated by hemorrhage, the lesions may be of increased density. Calcification may occur in the wall. On MRI, the cysts can vary in signal intensity based on the content, whether it is transudates or blood. They are dark on T1 and bright T2, and lack enhancement generally. On simple, if they contain high signal intensity, that means there may be hemorrhage inside. So low T1, high T2 with no enhancement of the walls. Hepatic cysts in a male 55, multiple cysts. We have the possibility of biliary hamartomas, and we can have also the possibility of polycystic liver disease. But the appearance and the size of the cysts and the numerous scattered cysts there in the MRI of this patient may point more to biliary hamartomas. We have multiple cysts with septa and bulging and soft tissue changes, soft tissue nodules. We will consider this as biliary cystadenoma And as we said, in biliary cystadenomas, which are rare tumors occurring in middle age, they are generally intrahepatic, unilocular, but may present multiple septa, and they are closely resembling that of hydatid, but in hydatid we have the contents all are enclosed in one cyst of a smooth outline, no focal bulges, and no soft tissues, and no blood inside. Clinically, there is in biliary cystadenomas there is no fever, while in hydatid there is fever. In malignancy, there is history of malignant wave. If they are considered as deposits, there should be malignant lesions there. So this is the appearance of biliary cystadenoma with multiple cystic lesions with focal bulges. Focal bulge is a very characteristic for biliary cystadenoma. Soft tissue thickness in some parts, and here we repeat the whole story again, that biliary cystadenoma generally are intrahepatic, unilocular with multiple septa, and there is close resemblance between this and that of the hydatid, yet the septa is maybe thick, maybe enhancing, maybe mural nodules, and thus we can distinguish this from either hydatid cyst. If the contents is hemorrhagic, this will produce the increased T1 signal intensity, and biliary cystadenomas are predominantly of high signal intensity on T2 due to the cystic components, of course, but the intercepta are lower in intensity, but they tend to enhance. The features favor malignancy are the increasing or significant soft tissue components within the walls of the cyst, as mural nodules or thickening of the wall, or thick septa, and this will of course enhance after contrast. And with the focal bulge, this to differentiate cystadenoma biliary from the hydatid disease. So what is this? Here we have one cyst that's well defined with calcific outline, and you have a lot of cysts inside. This is typical appearance of the multiple daughter cysts, and here there is one cyst with separate germinal from the cutaneous layer, and they are more than one, even involving the kidney. This is hydatid disease. Of course, there is a long differential, but mainly biliary cystadenoma, which is different from that, in the following. One is that it is unilocular with multiple septa. It may be with focal bulge, no calcification on the margin, and the septa may be thickened, may be irregular, may have soft tissue inside as nodule, and all such things will enhance, while in hydatid the process is different. It is smooth, with calcific, with daughter cysts, with water lily or separate germinal layer, or multiple cysts as here, or abnormal content seen in ultrasound. This is the appearance: separate germinal, multiple daughter, and abnormal soft tissue within the ultrasound. Different types of hydatid disease: one single cyst or smooth outline, almost circumferential growth, and showing multiple daughter cysts. They can reach into the lung, they can be within the lung, they can open into the lung. This is another appearance of the big cyst with abnormal soft tissue inside, abnormal component of soft tissue, which should raise the possibility of hydatid. Of course, the associated fever and the multiplicity, usually multiple, and the presence of sometimes calcification can give a clue for the diagnosis. Another one with abnormal soft tissue at one side, and the cyst is there. This is a growing hydatid. Echinococcus cyst or hydatid disease has well-defined hypoattenuating masses with defined calcific or non-calcific wall. They tend to be large, multilocular, more than unilocular. Smaller dorsal cysts within the cyst may be present in 75% of cases, generally along the periphery. Complete detachment of the cyst membrane with a collapsed cyst within a cyst produces the water lily sign. Biliary cystadenomas may manifest as large but not calcify. This lesion can be differentiated from hydatid due to the presence of mural nodularity, and they generally don't have daughter cysts or water lily sign. In addition, clinically or laboratory findings usually can distinguish. Hepatic abscesses may contain air and wall enhancement and thickening, and don't forget that the margin is ill-defined. Metastatic disease is usually multiple and occurs in the setting of malignancy. There should be a history of malignancy. Hepatic cysts are homogeneous, round, irregular, and without enhancement. This is a resume or a briefing for what we have noticed. Hydatid disease is caused by Echinococcus granulosus or multilocularis. The more common form is due to granulosus and is contracted from eating infected food or from contact with infected dogs. The disease is endemic in Mediterranean basin and sheep raising countries. This is the appearance of ill definition and multiple locularities of the abscess. This is abscess. So the differential is pyogenic abscess, hydatid disease, and hematoma, but of course the ill definition of the margin, the edema surrounding the lesions, and the multiplicity and the presence of satellites point more to the diagnosis of abscess. Remember that the list include pyogenic abscess, hydatid cyst, which is not, because it's not well defined, it's ill defined, hematoma, which is not the case, biloma, necrotic metastasis, no multiplicity, and biliary cystadenoma, which should be of well defined enhancing margin. Another case of pyogenic abscess. This is the typical appearance of pyogenic abscess. Don't expect the abscess of the liver to be a big cavity, except in amebic one. But the pyogenic abscess is usually multilocular with ill-defined margins and clusters of breaking down areas like this. Here is another example of abscesses of ill-defined margins and multilocularities, and air seen within some of the biliary radicals. Abscess with calcification is typical for amebic. Of course, hydatid disease is another possibility. That means parasitic affection is usually tends to calcify. Hepatic amebiasis is caused by Amebiasis, which is endemic in India, Africa, and Far East, Central and South America. Hepatic infection results as colonic trophocytes ascend via the portal veins and invade the hepatic parenchyma. Of course, by serum, it's positive antibodies in 90% of cases, but these tests may be negative in acute stages. CT findings may be non-specific. Most cases involve right lobe. Amebic abscess can occur as one or more well-defined hepatic masses with complex fluid, which may contain internal septation. Thick enhancing wall measures 3 to 15 millimeter, and the peripheral rim of edema. Extrahepatic extension is involving chest wall, pleural cavity, pericardium. It tends to extend. The clinical history and the positive tests are suggested. Of course, we can aid in the diagnosis. Amebic abscesses can be differentiated from some other hepatic lesions by the presence of thick enhancing capsule and extrahepatic extension. These are two important things, plus the possibility of being calcific, having calcific wall. Candidiasis can produce small multiple scattered cysts of ill-defined margins with again clinical suspicion of fever, clinical association with fever. This occur here in a fatty liver. Thank you.